My name is Mariangela Pellegrini. I'm Patients and Educational Manager for the ERN-EuroBloodNet, so the European Reference Network on Rare Hematological Disease. And it's my great pleasure to welcome all of you on behalf of the ERN to this session of the EuroBloodNet Thursday webinars. Before starting, I would like to share with you some technical information. So as you may have noticed, this session is recorded because it will be implementing in our e-learning platform and YouTube channel. So if you don't feel at your ease, please put off your camera or write up pseudonyms on your names. And also be kindly informed that your microphone is muted for the long of the presentations. And if you have any questions, as we wish, about the presentation, you can write them in the chat whenever you prefer, and they will be addressed during the Q&A session at the end of the presentation. And well, I guess everyone know where the chat button is. By the way, it's at the bottom of the screen of the platform. So as you know, the aim of this educational appointment we have is to promote the interest on very innovative topics in order to stress among health professionals the cutting-edge advances in the field of rare hematological disease. And today we are going to assist to a lecture on pathogenesis, clinical presentation and management of congenital erythrocytosis, led by Professor Holger Cario. So as you know, he's consultant for pediatric hematology, oncology, and hemostasis, and clinical head of the Laboratory for Special Hematological Diagnostic at the Department of Pediatric and Adolescent Medicine, Ulm University Medical Center, speaker of the Center for Rare Hematopoietic Disorder and Immunodeficiencies, Center for Rare Disease at Ulm University Medical Center, and Associate Professor of Pediatric at the University of Ulm in Germany. He's also author and co-author of several national guidelines in the area of non-malignant hematology, board member of various study groups within the German Society of Pediatric Oncology and Hematology, and past elected GPOH board members. He is member of national and international scientific and medical association, including EHA and ISH, and long-standing scientific collaborator of the Thalassemia International Federation. So dear audience, please welcome with me the speaker of today's session, Professor Holger Cario. Please, the floor is to you.
Mariandra, thank you very much for this very kind introduction. Dear colleagues, it's a great pleasure and honor for me to give you this lecture on congenital erythrocytosis today. Actually, the title is promising very, very much, and I hope I can at least cover some of these points, because you have to be aware that these are very, very rare disorders, and systematic data, particularly on the clinical presentation and management, are actually missing. So I have no conflict of interest to declare in the context of this topic. And here are some points what we want to occupy with during this afternoon. So I will talk about classification and diagnostics and congenital erythrocytosis, and on the clinical and pathogenic background of some subtypes of this group of disorders. And we will follow a diagnostic pathway in an individual patient throughout the presentation. And at the end of this lecture, I will come to some overview on useful and other more questionable approaches to treat congenital erythrocytosis. So we start with the case presentation here. We have a 10-year-old female patient in good clinical condition without any physical, neurological, or other abnormalities, with an accidental diagnosis of erythrocytosis at the age of 3.5. At the time of this presentation, the girl has a plethoric face, mild jaundice, liver is enlarged mildly, otherwise it's a normal physical status. This girl underwent several phlebotomies during the last 6 years, 2 over the last 2 years, when she was complaining for hyperviscosity symptoms like Hestis, and it was okay, and relief of symptoms after these phlebotomies, but it's very rarely done. On the right-hand side, you can see the blood count with a high hemoglobin and hematocrit level, normal leukocyte platelet counts. We see mild iron deficiency with a low ferritin, some increase of the transferrin receptor, erythropoietin within the reference range, whatever this means, and we have a normal P50 of oxygen saturation, so a normal oxygen affinity of hemoglobin, obviously. Now we come into the details. So it is important to recapitulate that we are occupying with absolute erythrocytosis, so which has to be distinguished from relative types or some apparent erythrocytosis, which is somehow a combination of reduction of plasma volume and increase of red cell mass within the respective reference ranges, but absolute erythrocytosis means red cell mass is increased. We distinguish then, sorry, it reacts too fast or too slow, however one want to regard it. So we have to distinguish primary and secondary erythrocytosis. Primary means there is an intrinsic defect in the red cell precursor cells, independent of erythropoietin, leading to a proliferation of those precursors. And we have secondary erythrocytosis, which is driven by some extrinsic stimulus, usually erythropoietin. There's at least one disorder with an overlap of both these characteristics, but usually this is a rather reasonable classification of these two subtypes. For both primary and secondary erythrocytosis, we have congenital forms, meanwhile classified in OMEM very extensively, and we have acquired forms of those primary and secondary erythrocytosis. When we want to go further into details of these single types of erythrocytosis, we have to keep in mind the regulation of erythropoiesis, which starts with tissue hypoxia, either by inefficient oxygen supply or by other causes of hypoxia. This is then sensed by interstitial cells of the kidney, where EPO is produced, stimulating bone marrow cells to proliferate and to expand, and then correcting oxygen supply for the tissue. And all of these parts of this regulatory circle may be affected by congenital or acquired types of erythrocytosis. So starting with the low tissue oxygen release, we have on the side, of course, of acquired forms, all cardiac pulmonary disorders leading to such hypoxia. And then we have on the congenital side, we have all these causes which are related to some alteration of the hemoglobin oxygen affinity, which then in turn, and we come back to it later, to a reduced oxygen release to the tissue. We then have on the side of the kidney, of the oxygen sensing, also some congenital defects, meanwhile creating a group of disorders affecting adequate oxygen sensing and leading to an inadequate erythropoietin production. Erythropoietin itself may be produced by tumor cells in the case of autonomous EPO-synthesis, acquired disorders, various tumors leading to such EPO production, many of them related, for instance, to the von Hippel-Lindau syndrome, VHL syndrome. And finally, on the side of the red cell precursor cells, we have the well-known acquired form polycythemia vera, and very few, so finally one a secure type of congenital form with EPO receptor mutations. And there are some reports on possible involvement of LINC as a second gene, which may lead to primary congenital erythrocytosis. And then we have, of course, to find an approach to diagnose these disorders. And you can see here with these colors at the end, all these groups of congenital disorders that I was talking about. We start with the exclusion of an acquired erythrocytosis, primarily by looking at oxygen, peripheral oxygen saturation, but of course also by careful physical examination of the patients and added by cardiology and pulmonology assessment examinations of the patient. If this is excluded, or rather probably excluded, we then have a look on the EPO levels. So there's actually, it's discriminating not very detailed, but at least for two disorders, we would expect low serum EPO levels. So first, in the case of polycythemia vera, of course, we know that there are few patients also with low normal EPO levels. And of course, we have to exclude these additional signs and symptoms of PV. And the other disorder is congenital erythrocytosis caused by EPO receptor mutations. You can see that our patient has a EPO level within the normal range, so it's not the case in our patient, but nevertheless, we start for systematic reasons with primary erythrocytosis. I don't know. So we were at a point to talk about these EPO receptor mutations. Actually, it took 25 years after these last Olympic Championships of Euro-Mantaranta that the underlying cause point mutations in the EPO receptor gene was detected in 1993. And actually, this was based on a very large pedigree that you can see here. And it's important to know that not everybody was just a fit sportsman like Eero-Mantaranta was, but there were several family members affected by, for instance, myocardial infarction in the early 40s. Other had thrombotic events. So a very heterogeneous clinical presentation, but he actually did benefit from it. So all these mutations, or the vast majority, almost all mutations, lead to a truncation of the intracellular EPO receptor part, just leading to the loss of some important tyrosine residues, which are important for the negative feedback of an once activated EPO receptor. And this leads finally to increased EPO sensitivity of the erythroid precursors. A variety of mutations had been described since this first description. As I said, almost all of them were nonsense mutations leading to a truncated receptor. The clinical presentation is very heterogeneous, even in one family, as I showed you from the original ones. Here's one of, so this was the first family that we saw with the index patient in the middle, who had absolutely no clinical symptoms and was diagnosed by chance. His mother actually had erythrocytosis during childhood and adolescence, but now has an almost normal hemoglobin level, but very low EPO. And on the other side, we have an older brother who has experienced a deep venous thrombosis at the age of 15. So heterogeneous even within one family. We then come now with a normal or EPO in the reference range. What does it mean? It means that EPO is inadequately high for a high hemoglobin level, of course. But other patients, of course, present even with truly increased levels. So in this case, the next point we are looking for is the P50 of oxygen saturation of the hemoglobin, and which was normal, as I said, in our patient. And the first group are those with a decreased P50, and we come to this group next, We start with hemoglobin variants with an increased oxygen affinity. So the first one was actually described many, many years ago, 55 years ago, hemoglobin Chesapeake, and more than 200 variants had been described, 1/3 of them associated with erythrocytosis. They actually affect all parts of the alpha and beta globin gene, finally leading to the stabilization of the oxyhemoglobin configuration. And this leads in turn to a decreased oxygen release into the tissues, to a leftward shift of the oxygen dissociation curves. And this decreased oxygen supply for the tissue finally leads to increased EPO production and a compensating erythrocytosis. And a similar mechanism is working in the case of 2,3-DPG deficiency caused by bisphosphoglycerate mutase variants, which had been described in very few patients, and finally make the same because it leads also to a leftward shift of the oxygen dissociation curves. And then in addition, there are single individual patients with PKLR, activating PLR mutations with the result of ATP increase, 2,3-DPG decrease, and finally the same result, compensating erythrocytosis. If the P50 is normal, so we come to another group of congenital erythrocytosis. These are those diagnoses with defective oxygen sensing. So to understand those disorders, it's important to know how EPO is regulated. Actually, as you know, it's regulated by the hypoxia-inducible factor 2-alpha, which is regulated not by transcription of carbohydrates, but primarily by degradation. And in the case of oxygen supply, adequate oxygen supply, if it's degraded by proteasomal degradation after ubiquitination by the von Hippel-Lindau protein. And to make this possible, a number of factors is essential to lead to VHL binding and trend processing. Two of them are the prolyl hydroxylases, another one is FIH. So finally, all these parts of the oxygen-dependent degradation of HIF, which is finally the major transcription factor, together with then a beta subunit and some other factors to increase EPO transcription, may be involved in congenital erythrocytosis due to oxygen sensing defects. The first one, which was explored more in deep and with the detection of the underlying cause, is Chuvash polycythemia, which had been actually described almost 50 years ago from the clinical point of view. Chuvashia is a very small region, a republic, autonomous republic in the middle of Russia, very close to the Ural Mountains. And there, an endemic form of erythrocytosis had been described by the colleagues. And in 2002, the underlying genetic cause was identified. I come to it in a moment. But this disorder is actually associated with very severe clinical findings. We have a large part of patients affected by thrombosis, some even of bleedings. We have silent infarctions of almost half of the patients. But in addition, we have some typical findings which shows that not only HIF2-alpha, but also HIF1-alpha certainly is activated, but other factors than erythropoietin will play a role, and these are the hemangiomas and varicoses. And in addition, another typical clinical symptoms in those patients, which is related not only to erythrocytosis, but certainly primarily by the elevation of other hypoxia-dependent factors, is pulmonary hypertension affecting those patients, in contrast to low systolic arterial pressures. And actually, pulmonary hypertension is even worsened by phlebotomy. in those patients. And that's an important finding for the clinical management, because they benefit not very dramatically from this treatment and can even worsen their clinical situation, certainly related to iron deficiency induced by this regular phlebotomy. The underlying genetic cause in Chuvassia and Chuvash polycythemia is a point mutation in the von Hippel-Lindau gene leading to this amino acid change. This finally was found in not only in the region of Chuvassia, but also in other parts of the world. And one study examining haplotype of the VHL gene came to the conclusion of a common founder of this mutation. We know that at least in one other family, there is a separate development of the same mutations in another pedigree. But the majority of patients certainly goes back to this isolated founder. Since that time, a number of different mutations within the VHL gene, as either in combination with the 200 mutation or isolated, are described, and there are two other endemic clusters of VHL-related polycythemia, one on the island of Ischia in Italy with the same mutation than the Chuvash patients, and with a different mutations. There's a cluster in Croatia. More recently, it was seen that not only point mutations leading to amino acid change within the gene lead to erythrocytosis or even von Hippel-Lindau disease, but also intronic variants and synonymous exonic mutations leading to splicing aberrations also can cause erythrocytosis, or in some cases even von Hippel-Lindau disease. The next type of oxygen sensing defects was the detection of mutations within the gene EGLN1 encoding for proline hydroxylase 2, which is here in this regular circle. And this actually leads to a reduced HIF binding and HIF hydroxylase activity, thereby stabilization of HIF, leading to more EPO transcription. And as you can see here, a number of mutations have been described also for this type of erythrocytosis, and at least one of the patients was described with a coexisting paraganglioma, something which is related to the same area of disorders that you can find in the von Hippel-Lindau syndrome. Interestingly, and I forgot this, very, very few patients with VHL-related erythrocytosis have also neoplasms similar to those found in the classical von Hippel-Lindau syndrome. The last factor affected in the regulation of HIF, of EPO, is HIF mutations itself. They lead finally to a reduced PHD2 binding and proline hydroxylation, and thus to lower binding of VHL and a loss of degradation and thereby stabilization of HIF2 alpha, with the same result of high EPO and erythrocytosis. And also for this gene, several mutations had been described in the past. For HIF2 alpha mutation, at least, it's also known for almost 10 years now that it also leads to pulmonary hypertension, similarly to the results that we had seen in VHL-related erythrocytosis. And here again, we have the problem how to manage it, because phlebotomy can, in principle, worsen the situation. The last factor concerning oxygen sensing are mutations in the EPO gene itself. And actually, two of such families with segregation of a change within the EPO untranslated region had been described in the context of a large whole genome sequencing study. Actually, for this mutation, we don't have the exact mechanism so far. But we know the mechanism in another type of EPO mutations, and which was described by Jakub Smajkovic and Radik Skoda's group several years ago, with a deletion in exon 2. And they actually got this hint to examine this further because it's very strongly segregated with erythrocytosis in this perigray. And another similar mutation in the same gene was described a few years before within a series of patients undergoing next generation sequencing, where I also was involved. Actually, this was one of my patients. But we and later also the colleagues didn't understand first why does a deletion in this exon with as introduction of a stop codon would lead to erythrocytosis. And actually, Jakub Smajkovic and colleagues could show that on one hand, the normal, the translation of the normal transcript can't occur because of this frame shift, but there is a second form, usually non-coding RNA, which is transcribed by using a different promoter and leading to the production of another type of EPO, and finally resulting in high EPO and erythrocytosis. Now we come back to our patient, and actually I have to say that we didn't find anything first in the known genes. We then also included this patient in the analysis with NGS, and we could find a JAK2 mutation. But finally, this is a not so rare SNP, and the mother was healthy and had the same mutation, so this was not the explanation. Finally, in this patient, whole genome sequencing revealed this type of change, a mutation within a gene called SCL3810. And this gene encodes for a human manganese transporter. And several years ago, a syndrome with hepatic cirrhosis, dystonia, polycythemia, and hypermanganesemia was described by colleagues, and also clarified what is the underlying genetic cause, and it's actually mutations within this gene. These patients usually present primarily with severe neurologic symptoms, particularly with dystonia, with gait disturbances and similar findings. But they all have also erythrocytosis, they have iron deficiency and liver disease. Actually, there was no patient described before who had isolated erythrocytosis, how our patients. All these patients have high manganese levels, iron deficiency, as I said, and high EPO. And they have intracerebral changes leading to all these neurologic symptoms. Actually, it's known for more than 20 years that manganese is actually an element which can interfere with EPO production. It was known from other observations, and it fits very well with erythrocytosis seen here. Why is it important to detect this disorder? We have, in principle, we have the possibility to treat it with chelation. Chelating a manganese will lead to maybe to avoid further neurologic disturbance. This was shown that it even can ameliorate neurologic symptoms. So if you see it early, you can do something against this disorder and its further progression. Additional treatment may be iron supplementation, because there is some concurrence between iron and manganese in the uptake of the divalent metal ion transporter in the intestinal mucosal membrane. So it's good to have this rather high to avoid too much manganese resorption. Finally, therefore, we should include this disorder into our differential algorithm for erythrocytosis, which was done here in this case. Okay, at the end, we come to the treatment. Actually, as I said in the beginning, we don't have systematic trials on treatment in those patients, particularly not medical treatment. Concerning so I listed here some treatment, which is the three first. You know it from polycythemia vera as usual treatment options. So what about this type of treatment in erythrocytosis? I said in PV it's established usually together with aspirin, but in a congenital erythrocytosis, I think we can do this very well in erythrocytosis related to EPO receptor mutations. But as I did show you, in some types of erythrocytosis, it may even worsen the clinical situation. And in those within compensatory erythrocytosis due to increased oxygen affinity, it may be a possibility for short-term intervention, but people need high hemoglobin. So just in case that it's not possible to manage otherwise, one would even have to think about exchange transfusion in such patients. Okay, next option in polycythemia vera are interferons or hydroxycarbamate, well established in PV. So what about in erythrocytosis other than PV? So there's actually at least one trial examining the hydroxyurea in secondary erythrocytosis. It's done in patients with erythrocytosis due to cardiac disorders. And what the authors observed was after hydroxycarbamate, they have not so much change in the hemoglobin level, but they lower the hematocrit, which leads to a lower viscosity. This is associated with a lower red cell number, with higher MCV and MCH, with maybe a better deformability. So actually, they did show the relief of hyperviscosity symptoms, and it was well tolerated. So in some patients, it may be an option. Ruxolitinib is an accepted second-line treatment, or even meanwhile first-line treatment in PV. What about other erythrocytosis? So there is at least this paper presented 5 years ago in 3 patients with Schuber's polycythemia. And what I forgot to say is that this is the disorder where you have characteristics of both primary and secondary erythrocytosis, because we know that there is some hypersensitivity to APO in such patients, maybe due to other functions VHL is doing in erythroid precursor cells responsible for the degradation of other proteins involved in EPO sensitivity as well. So what the authors could show that they did see a hematologic and symptomatic improvement in those patients, and with mild decrease of hemoglobin levels, but a reduction in phlebotomy treatment, and finally amelioration of clinical symptoms. We're coming to some remaining possible drugs. So first, we know from patients who are suffering from renal, from erythrocytosis after renal transplant, that angiotensin converting enzyme inhibitors or angiotensin receptor blockers, as well as theophylline, had been studied in such patients. And there, as you can see, there are several studies performed in those patients, which lead to a reduction of the hematocrit in many of the patients, not in all. But it's an interesting approach because it's known that this angiotensin system, as well as like IGF, is stimulating erythropoiesis and maybe leading, at least in those patients, contribute to erythrocytosis. There was one randomized study comparing one of the ACE inhibitors with theophylline with favorable results for the ACE inhibitor. And as you may know, it's obviously also less side effects of this drug as compared. So if one will try it in the patients, I would say ACE inhibitors or AT1 receptor blockers. I think it's worth if you have a well-tolerated drug to try it and to maybe to have some decrease of the hematocrit. The other drug which is interesting is digoxin, which was shown that it it may inhibit hypoxia-inducible factor. Better for HIF1 alpha than for HIF2 alpha, but nevertheless for HIF1 alpha, so it's very remarkable effects on its function, as you can see from this oncology study. And actually, some colleagues of us, Victor Godek and Joe Pacao in the US, wanted to start a trial on it. And it's also one registered in clinicaltrials.gov, but so far they didn't recruit. And finally, if we come to some new inventions, these are HIF2 alpha inhibitors, which were studied extensively to target renal cell carcinoma, particularly in VHL patients with these antagonists, and it was shown that it was very effective in cellular experiments as well as in clinical trials. And rather recently, a study in neuron models of Schubert polycythemia, but also in erythrocytosis due to a knockout of an iron-related protein leading to erythrocytosis, was shown that these HIF2 alpha blockers are very active in reducing hemoglobin content in erythrocyte counts in those patients. And actually, the good news is that in August this year, the FDA approved this HIF2 alpha inhibitor for cancers associated with von Hippel-Lindau disease. So there is at least one now licensed drug, not licensed for the erythrocytosis, but there is something approved for other diseases, which could be an option for patients with the group of disorders of oxygen sensing at all, with the exception, of course, of a mutation in the EPO gene itself. And now some very other thing which I found by searching for possible treatment alternatives. So in the mid-80s, there's was this type of study presented to make a hookworm infestation in a patient, which of course is a very interesting approach, because you have bleeding, you have iron deficiency, and you have inflammation, also inhibiting erythropoiesis and EPO production. I think it's not an approach that we can really convince our patients to undergo, but I find it's a very interesting thought. So to come to the end, we have an increasing knowledge about etiology and pathophysiology of congenital erythrocytosis. But in the majority of cases, at least from my knowledge, we have the underlying cause still unexplored. And maybe in some of the, or maybe in many of these cases, polygenic pathogenesis might play a role. Clinical data are very, very sparse, and we can only obtain them if we collaborate. So far, no systematic data are available. And clinical trials are, because of the rarity of the disorders, very difficult, will be very difficult to establish. Treatment is difficult. Phlebotomy is easy to perform, but which threshold should be used? And it may even worsen some cases of congenital erythrocytosis. And among the new options, that's really my hope, the HIF2 alpha inhibitors are the most promising approaches. And that's at the end of my talk. I have to thank many, many colleagues with whom I had the big chance to collaborate. Thank them and thank you for your attention.
Thank you very much, Professor, for this great and comprehensive presentation. So now there is the possibility to answer and address questions, the other way around, to address questions and answer. So I really encourage the audience to take profit of this unique occasion to ask questions directly to an expert of a such specific clinical domain. So in the while that you formulate your questions, I just want quickly remind you that on our YouTube channel and also e-learning platform on our website, there are all the past sessions of these Thursday webinars. And also this one will be available on those tools. And on the website, you also will find the following sessions, if there is any that is interesting or sounds with your domain of interest. And also, Professor, do not hesitate to ask questions to the audience. If you have any curiosity on best practices or whatever, sometimes we never thought the other way around, but there have been sessions where it was the speaker asking questions to the audience for curiosity.
Yes, so maybe one point which I think is asked very frequently is the question of certain threshold hematocrit levels or so, which should be guaranteed in patients with erythrocytosis, and this I'm asked very, very frequently. And I think it's very difficult for all those types that I presented to you. And that's the key message. I think in the center of our thoughts, the clinical presentation of the patient should be there with either having or having not hyperviscosity symptoms, or even, of course, if experiencing severe thromboembolic events, then it's no question. But in all those patients who don't have any symptoms, very difficult to decide. And I can tell you that the highest hematocrit level that I ever have seen in one of my erythrocytosis patients was a hematocrit of 80%. Once, but higher than 70 several times, without any clinical problem, in a very young patient, so with a very healthy body, with a very healthy vascular system and so on. But I think it's important to know that for some of our patients, even can worsen the situation if we phlebotomize them too aggressively. We don't have to have the target to keep them below 45 or so, like in PV, but it's a very individual decision that we have to make. But maybe you have some questions to me. Maria, I can't hear you.
No, I cannot see any questions arriving.
I see that Maria Luigi
Maria, not Maria,
tried to talk, but I didn't hear her.
Now, yes, maybe we can hear. Sorry, it's the same name. I thought you were speaking to me. It's Maria Luisa, go ahead.
Hi, Holger. Thank you for this nice presentation. I know that also patients with the erythrocytosis that we call idiopathic erythrocytosis are prone to a higher risk of thrombosis than general population. They have a lower risk than PV, but have a higher risk. I unfortunately lost your first the first part of your relation. Maybe you have talked about that. I do not know. Can you say us something about thrombosis in idiopathic and unknown erythrocytosis?
Yes, so actually I concentrated on those which are known, which is maybe one third or so of our patients, and I think the majority we don't have. But even for those with the known cause of disease, with the exception of Chuvash and the similar, where we have clear data because of this endemic situation there, but otherwise we have very few data, and we have a very heterogeneous presentation. As you say, we have a higher risk really, as compared to other to the healthy population. But as long as we can't classify the patient, we can't say for an individual patients we can't determine any risk, and even more than to make a decision, for instance, for prophylaxis or something like this. So I think something, for instance, like anticoagulation, also, I would really preserve to those who experienced problems, and then to continue. You have to yeah.
No, thank you. Thank you very
So,
much.
thank you to both of you. I can see there is one question in the chat from Grasa Porto. What about the risk of iron overload to low hepcidin?
Oh, very interesting question. Yeah. In fact, what I see in the patients is more iron deficiency, actually, in the majority of these patients, because they can't meet the requirements. And I never saw patients with high iron storage. So I think it's a question of both. So once you have erythropoietic activity, increased low hepcidin, more iron resorption, but on the other hand, you have it is really used to produce red blood cells, and at least those all patients whom I know have iron deficiency rather than iron overload. I don't know whether you made other experiences, Maria Luisa. Oh.
I am recently working about the patient with iron overload, because I found that patient carrying the HFE mutation, that it is always considered a polymorphism, not a mutation really, have a higher increase of hematocrit compared to other people. And they have also sometimes also thrombotic events. And this is common not only in patients with polymorphism, but also with those with the real hemochromatosis. Yes. And I am looking for polycythemia. How is it in patients with polycythemia? How many have an iron overload? Because I want to look at the other side of the problem, but at present I have not a clear idea. I recently found a couple of families with TFR2 mutation. I presently did not publish them because we are going on with the studies and we have nothing to say at the moment. But I think that there is a relation between iron metabolism and erythrocytosis. But it is obvious, I think.
Yes, but I think it's this way around. So that's what I know. Also know that these HFE changes may be associated with erythrocytosis, but on that the erythropoietic activity per se leads to increased iron overload. That's something at least that I didn't observe yet. Any other question? Not the case.
No, it looks not. So, well, thank all of you for being here. So thank Professor Holger Cario. No, there is one question. Thank you for the great presentation. What about this rare mutation in people with polyglobulia and membrane defect associated with hereditary spherocytosis?
So actually, I'm not sure whether you mean spherocytosis, but rather recently there was a publication of the French colleagues on patients with dehydrated stomatocytosis or xerocytosis as a defect with in PSO1 as the responsible gene, where they found actually in their cohort of patients with erythrocytosis a subgroup of patients which have these types of mutations, which is actually related to two problems usually. One is hemolysis, and the other is iron overload because of disorder of hepcidin regulation, where PASO1 is also involved. And so this is this one quarter of patients. And what we can actually observe is in some, it's a rare disease, in some of those patients that I see also at least rather high hemoglobin levels. I know about 12, 15 patients with steatosis. None of them has really polycythemia erythrocytosis, but that was described there. But I can say you something also to spherocytosis, because so I don't know any publication on it, but I personally have patients with a certain subtype of spherocytosis without splenectomy having high hematocrit hemoglobin levels. And I know from personal communication from colleagues that there are some of these patients, and it's really worth to collect those patients and to try to understand why a typical mutation associated with spherocytes, with hemolysis, leads to true erythrocytosis as defined by hemoglobin levels, hematocrit levels below 99th percentile of the age-dependent range. That's an interesting story, but related to spherocytosis, I don't know any systematic approach to it. Okay, interesting. You're right. You have some with Anki and spectrum defect. I can say I have some with Ben3 defect. Maybe we should communicate about and try to find a solution, some way to resolve this enigma.
Okay, so thanks all of you for this great session. Thank you for having accepted our invitation and for having held such a comprehensive lecture. So thanks again and have a nice evening.
Have a nice evening too. And once again, excuse me for these technical problems. I don't know what's wrong. I have to change the computer. It's 10 years old. It should be on a waste. Thank you very much.
Thank you. Bye-bye.
Bye-bye.